Augmentin. I don't like Augmentin. I don't use Augmentin anymore. Way back when, it's amazing to me. I used to give 30 years ago, 25 years ago, I gave a lecture called the 6 antibiotics you could treat every lower extremity infection. And to this day, people who are like my age roughly come up to me and say, Warren, I still have notes from your 6 antibiotic lecture. I haven't given it in 25 years. That's before MRSA was an issue. And Augmentin was one of those. You know when I stopped liking Augmentin? When I personally had to take Augmentin. Have you ever taken it, Ben?
Yes, yes, it does do some GI stuff on you for sure.
Yeah, yeah. I mean, the pill's this big, and you have to take it with a full glass of water. And yeah, I would take it, and I felt like my GIs, my stomach was going to jump out of the lining, of the abdomen. It's nuts, uncomfortable to take. I don't want to submit patients to that if I don't have to. So I stopped using Augmentin, and it's just too difficult to take. It's got good spectrum. It's got the anti-anaerobic spectrum because it is a beta-lactamase inhibitor compound. It has some advantage with gram negatives over cephalexin. It's got the enterococcal coverage, which cephalexin, Keflex does not have. But I can't justify using it anymore from an adverse event profile. So I don't really use it anymore. And I used to talk about using that like amoxiclav along with one of the quinolones like levofloxacin. I'm off quinolones. And you and I have discussed this. We know that quinolones, the number two cause of C. diff, potentiate resistance by MRSA, potentiate gram-negative resistance. More quinolones have been pulled from the market than all other antibiotics combined. There is no reason for a podiatrist to ever use a quinolone unless they have a documented gram-negative infection that is shown to be susceptible. We were talking about one of the gram negatives, and you asked me how to cover it. And I said, well, you have IV. There are a number of IVs that can be used, or there's one oral, and that oral happens to be a quinolone, levofloxacin, for instance. So in those cases, yes, it's an appropriate drug to use. But I don't like it. I don't like amoxiclav. I don't like quinolones anymore. As for resistance, MRSA is not the big deal that it once was. Rates of MRSA worldwide have come down. In fact, some really good papers lately in the diabetic foot literature, Larry Lavery's published in this field and a couple of others, have now shown that MRSA accounts for less than 10% of all diabetic foot infections. But that's also very regional and it's also very local. Where you are in Virginia and your practice, you might have a lot of MRSA. We don't see as much of it. I do see some MRSA down in the valley, the Phoenix area, with the cases that I get sent. So we do have some MRSA here, but it's not. I remember into the early 2000s, every infection that came in the door had MRSA. We're not seeing that as much anymore.